Thanks. Oh, it's Nicole and I. Okay. So thanks for everyone for coming today. People may come in, but I want to make sure Raja has enough time because this is a proposal defense for his master's thesis. Raja Cholan, as you may know, works on my Care Management Plus team, but is also a Master's of Science in Clinical Informatics students, and actually has been recently awarded a scholarship, which I'm sure he'll thank the institution for. He's been working on clinical quality measures, really delving deep into how they work now for many of the large health reform efforts across the United States, and then what they're going to look like for the future. So it's an incredibly important topic for many people who are trying to implement these, and we're very proud. So he's defending this proposal today, so there'll be general public time, and then we'll get together afterwards privately. So I know there's a fellows meeting just after that. We'll just need a few minutes. All right, thanks.
Hey. I think this is on. All right, thank you, Dave. So like Dave said, I've worked a lot with quality measures, and one thing he said is that I delved deep, and that's actually a good segue for the beginning of my talk, because I'm going to spend quite a bit of time on the background and explain to you some of the issues. So clinical quality language is a new specification released by HL7 for representing the logic for clinical quality measures and clinical decision support. However, I'm going to be focusing on the CQMs. And so I'll start with the definition. So right now in healthcare and in informatics, there's a goal to increase population health. And one way of measuring that is with these tools called electronic clinical quality measures. They intend to identify care gaps, and they're based on evidence-based guidelines. And they are calculated using data elements found in EHRs that look at different processes, structures, and outcomes. And they're becoming a fundamental part of payment with the Quality Payment Program and MIPS, which is the Merit-Based Incentive Payment System, where clinics and hospitals have to submit quality data. And right now, they just have to submit to be eligible. But moving forward, they'll be benchmarked against other clinics, and based on their performance, they'll receive reimbursement adjustments accordingly. So there's different parts of a CQM. I won't spend too much time on this example because I'm going to dive deeper into another example, but you might have your denominator, or you always have a denominator, which is a subset of patients for whom the measure is designed to address. And then you have your numerator, which is a subset of the denominator where some type of clinical action is supposed to happen, whether that's a medication or like you actually are looking at some type of measurement, like their blood pressure measurement, for example, in their record. And then some measures have exclusions where there are patients where it's inappropriate for them to receive some evidence-based guidelines, so you exclude them from the calculation and you avoid harms for those patients. And so to get so these are the parts of the CQM, and they have a special document that CMS releases. It used to be in the ECQM library. It's now called the ECQ Resource Center. You can access these as HTML documents. It's called the Health Quality Measure Format, or the HQMF. And here's a screenshot. It's this gray table. I'm also going to pull one up and walk you through it. And these are updated regularly. And so as you scroll through this gray table, you'll see there's a human readable definition, like the narrative description. There's some information about the clinical rationale behind the measure, who developed the measure. And then they also include this pseudocode, which is intended to help you walk through the logic. So it helps break down the initial population and the denominator, what diagnoses are included, the types of encounters that are specified, and then how you're supposed to exclude the patients and whatnot. And so now, I'm going to show you an example of this. So this is for tobacco use, screening, and cessation. This is actually a version 6.1. I'm not sure how this actually aligns with the current version, but this is for like the 2018 measurement year. And so you can see in this text description here, I'll just read it to you. Percentage of patients aged 18 years and older who were screened for tobacco use one or more times within 24 months, and, which is in caps lock, which is actually important, who received tobacco cessation intervention if identified as a tobacco user. So the first thing you have to do is like squint and look at this and figure out what this actually means. What is this actually trying to measure? And so the reason I highlighted the "and" is the first part of it is looking at screening for adult patients in the last 2 years. Did you ask them about their tobacco use status? And then the second part is, if they are a tobacco user, were they given cessation intervention or a medication? And then they actually want you to break this down into 3 different rates. 1 is just the screening rate. B is of the smokers who receive cessation, and then C is the composite measure, where you have to basically include your entire population as the denominator and then calculate your numerator the right way. And so as you scroll through this HQMF, like I said, there's some of the disclaimer and the clinical rationale. And then they help you, they sort of try to simplify the denominator and numerator, which is what I sort of tried to walk you through just now. And then you finally get to the pseudocode. And so here, when you look in the pseudocode, what's important is that for the first population, the rate 1 that they want you to report, they tell you to include tobacco non-users and users, which makes sense because that one was looking at just the screening. For population 2, it tells you to only look at tobacco users. And then for the third one, again, it tells you to use both because this is the composite measure. Okay. And so then, the next step is once you look at this, if you were to actually implement this, so Dave Dorr has a tool called the Integrated Care Coordination Information System. And so we ETL the data out, extract, transform, and load the data out of the Epic Clarity tables into this MySQL database. So here's just a snippet of the SQL code, which I actually wrote for this smoking cessation measure. It's a slightly older version, but you can see that translating it from the pseudocode or the narrative description into code, we actually have the smoking screening comes in as a text from the social history tab into this table in our MySQL database. So we actually have to do some text processing in SQL. It's challenging, and the implementation of this measure was pretty tough. And we were lucky, actually, for screening. There were it was semi-structured. There were these, I guess, smart phrases or something. So there were only 6 possible options for the text, and so we were able to break it down. But when you look at the cessation text, it was not structured at that time. Maybe they've updated it. So there was all types of variation in that field. So the reason I showed you all of this was to prove to you that implementing CQMs can be hard, as you just saw with that example. And I worked on this grant called the Evidence Now Grant Initiative, funded by the Agency for Healthcare Research and Quality on Dave's team. We worked with about 100 clinics in Oregon and tried to extract measures out of their EHRs. And there were different ways that the clinics generated their data, either directly from their EHR vendor reports, they might have connected to another HIT system, or they had data teams that wrote their own measures. And so we knew that there was this variation, and I attribute some of that variation to that process of looking at the measure specifications and then translating it into code and finding the right clinical data. And so about a year ago, one of our measures updated, and we knew that, and we were collecting these measures quarterly, and we knew that in the first quarter, about 3/4 of the clinics were submitting the old version, and some were submitting the new version. And so I was very interested in this variation. And so because of this variation, HL7 to assist has come up with the new pseudocode framework. So I showed you an example in that smoking cessation measure for the different populations. They're going to replace that with this new standard called Clinical Quality Language, which is a new pseudocode framework. It's supposed to more precisely represent natural language and reduce the burden. This is a direct quote from the ECQ Resource Center. Reduce the burden on implementers for consuming these measure artifacts. And I'll show you an example now. So this is a little hard to read. This is a new measure. It's not the smoking cessation measure anymore. this is appropriate treatment for children with upper respiratory infection. So this is the traditional pseudocode, the current version, and this is clinical quality language. So in the current version, what they do is, so they tell you here that you need to have a diagnosis of upper respiratory infection. And then within that, they tell you all the different types of encounters that the patient should have. And then, as you come down here, it tells you the numerator criteria, or it actually tells you the denominator exclusions before telling you the numerator criteria, which is whether or not the patient received an antibiotic within 3 days of the diagnosis. And this is for kids who are aged 3 months to 18 years. That's specified up here. And then they tell you all the value sets, which are the codes and terms to define these clinical concepts. And now, this is the new version. CQL defines the value sets first, which I think might be good, because now when they refer to those concepts later in the pseudocode, you kind of already know what they are. They also define the measurement period here, 3 months to 18 years, right away. They define the encounters and the diagnosis separately, which I think is helpful. In the first version, diagnosis and encounter was all sort of lumped together up here. And then they actually tell you the numerator criteria first. Exclusions aren't included here. It might just be this example, or they might, I don't know why. There probably would be a line for exclusions. And then what I think is interesting is down here, they actually tell you how to compute the measure, which is pretty simple. It's numerator divided by denominator times 100, but that's actually explicitly defined in CQL. So how is CQL intended to be used? This is the vision from CMS. So currently, this is the current process, which I sort of walked you through. You have the HQMF, and then there's this process of translating that from the measure specifications into an implementation. And right now, a lot of that translation is manual. There is a machine-readable specification as well in XML, and there are some systems that can translate that directly into code. But most healthcare organizations do require some type of manual translation right now, which is what we learned in that Evidence Now grant. And so what CQL is intended to do eventually is to have this translator, and so you can go directly from that pseudocode into a script, a SQL script or something that you can implement against your clinical data directly. But this is not a trivial lift. This automated translator, I don't know if it's even been implemented successfully to prove that it works. Maybe at a couple academic institutions or something, but it has not been widely implemented yet. And so this is the aspirational view, is that your CQL could be translated directly against different institutions' healthcare data. But like I said, this isn't a trivial lift, so probably for the next 3 to 5 years, there's still going to be a lot of this manual translating happening. And so that's why, for the purpose of this project is to specifically dive into CQL and try to assess the benefits and challenges. There's not a whole lot of literature about CQL. Most of the stuff is HL7 draft documentation. There are GitHub libraries with example measure definitions, and there's a lot of stuff about the translator. You can download some translator services to try to get your automated scripting. So what I want to do, in short, is a qualitative assessment to understand the benefits and challenges from semi-structured interviews with experts. And the hypothesis is that CQL will be perceived to be better in terms of the learnability or the interpretation of the logic of these measures. So the methods are pretty straightforward. I guess in one sentence, I've already said it, is to assess the benefits and challenges of CQL. And so I'll specifically go into each of these different components of my methods now. So the first thing I have to do, I guess it's more of a task, is prioritize measures to choose. So like the upper respiratory infection, I showed you the example of the old version or the current version of the pseudocode in the HQMF format and the new CQL format. I need to specifically choose measures to show during these interviews. So these are 4 that I've chosen, that I've narrowed it down to. And 4 might be too much to show in like an hour interview with an expert. So I need to prioritize which maybe 2 I'll use. And then I also need to think through the order of which that I'm going to present these to the experts, showing them the old version first versus CQL first. And so I'll touch on that a little bit more later. And so part of the reason I chose these measures is that they cover a variety of different clinical concepts, and they vary in complexity. So in the HQMF, it tells you the different value sets and quality data model elements. So I just counted those as a proxy to show you the complexity of these measures. So the first measure is a heart failure measure. It has 26 of these QDM elements. It includes meds and lab tests and encounters and diagnoses. And then some of the other measures only look at meds and encounters and diagnoses, and they have fewer elements. And if you actually look, just looking at the CQL, it's a lot shorter. And so I think it's important to show one maybe more complex measure. If I choose 2 measures, one more complex measure and one less complicated measure. Okay, the next thing I have to do is identify and recruit experts. So there are the HL7, there's a clinical quality information working group. They meet every week. And then there's the group that developed the draft measures for CQL, as well as the measure authoring tool is one of those places where they can do some of this automatic translation of the machine readable CQM definitions. So I could reach out to these people to get some technically trained people in quality measures that know about implementation and know about these specifications. But I think it's also going to be important to recruit people who are clinically trained who may not know as much about CQL specifically, but they still have to go through that process of reading the measures specifications and being able to articulate it for like a quality improvement role and see if how they interpret the new model. Next, I have to develop the interview guide. So this is an outline of the types of things that I'll collect. So for every expert, I'll collect information about their background and role and career and try to assess their level of familiarity with quality measures, HQMF, CQL, and just programming in general. And then when I show them the versions of the measures, really what I'm interested in understanding is what's confusing about looking at CQL, what's understandable, what's ambiguous, and then, collect all of that from the interviews. And a really important step as a part of this is piloting the interviews. So as I'm scheduling this, and this will happen soon, I have a timeline slide coming up. I'll pilot the interviews with 2 or 3 people so that I can get feedback, figure out what might be awkward or what can be improved. Should I send stuff to them ahead of time? So I actually have a couple people in mind already for who I can pilot with. So I'll briefly touch on some frameworks. So this was a framework I used by a guy named Smed about algorithms and pseudocode and how they're supposed to work. There's a lot of text on the slide, but basically he breaks down how an algorithm has these substructures and their relations, and they should be explained in a natural language. And so as I walked you through CQL, there were the different substructures, and they were showing the relationship between the different clinical concepts. And so I'm going to use this to help inform some of the questions I asked specifically about CQL and the current HQMF format. And then these I took from a reading actually from BMI 560, Komlinsky, Framework for Evaluation. So for accountability, I'm going to really focus on confidence and satisfaction with the interviewers. Accuracy, I'm not going to do any type of quantitative measure of that. I think I'm just going to try to heuristically determine if the people are right or not for the CQM logic and have them talk me through it as well. And then specifically, which will be helpful for the CQL community and the ECQ Resource Center, is highlighting any challenges. I actually talked to a guy that he basically invented CQL, and he told me it would be really helpful to get the gotchas so that they could iterate and improve it and strengthen the development of CQL. And then, yeah, evaluation for knowledge. So within the measure criteria, as I showed you in that example, there were temporal considerations, so you have to look at the measurement period as well as the age of the people. And for some of the criteria, like certain clinical actions have to happen in a certain time, like for the screening for tobacco use, it had to be in the last 2 years. So stuff like that. If there's specific elements that are either temporal or related to the clinical concepts or the way that they outline the diagnoses to include, I'm going to specifically try to ask about those. So I'll do the interviews, and I will transcribe all of those. I'm going to use an immersion crystallization approach to analyze it. And so to do this, I'll transcribe all the interviews, and we'll come up with a code book to label the text with my committee, and we'll have a standardization process around this and how to use them. Specifically, we're going to be looking at the benefits, challenges, learnability, ambiguity, confidence, satisfaction, and gestalt level as they look at CQL. And then we'll independently code the data and iteratively come back together to compare and reach consensus. And then I'll probably use Atlas TI as my software for this. One thing I forgot to mention in the recruitment stage is I aim to recruit 10 to 20 experts because that's where saturation is usually reached in this type of qualitative analysis. And then as we do this, we'll analyze the findings and group the things into concepts and themes. So I don't know how well you can see this. I'm hoping to start in spring term, start recruiting experts and doing the interviews in May, hopefully get all the interviews done by early June and move on into the analysis phase by then, which I think is doable to do 10 to 20 interviews in a month, especially since I know some of these people. I'm not reaching out to strangers. And yeah, with that, I think I'm done. I'm open for questions.
Hey, Russia, great work. That's I've done some more or less implementation of some of these, and you're exactly right. They're tremendously difficult to interpret, and I can see that definitely it's an issue across the board. My comment was basically, you know, there are a lot of people at OHSU here implementing and doing these kind of quality measures, and do you intend to really include those, and like Adam Stone, for example, chief of our reporting services, do you intend to include those people as well?
Yeah, I will. I actually haven't formally listed all the people I intend to include, or like the potential pool. I guess it's kind of like a quality measure. It's like my initial population, and then who's going to end up being in my denominator. But I absolutely would like to include people from OHSU, especially because I could probably meet with them face-to-face, where I could learn more just from that rather than all these virtual calls I'll have to set up. But I'm definitely going to leverage Dave's network, he knows Adam Stone and those people really well. And if you have other suggestions, I'll take those, or if you want to participate as well. Yeah.
Great talk. I have a couple of questions about how you're evaluating the clinician's performance, so to speak, or I guess mostly self-report looks like, in terms of how they did with the CQL versus I forget the alphabet soup for the other one, sorry.
Yeah.
This is all new to me. So the thing that puzzled me a little bit, or at least intrigued me really more, is the focus on using kind of self-report confidence satisfaction measures as opposed to accuracy. I was wondering if you could unpack that a little bit further as to why you decided that self-report about satisfaction and confidence might be better than accuracy, and whether it's even really that feasible, whether your measure of accuracy that you're claiming to calculate is really that reliable in and of itself.
Right. So initially, I had all these aspirations to show dummy patient level data, and then see if they could look at the CQL versus the current HQMF model and identify the right patients who should be passing and failing measures. And I thought about using like Likert scales for the confidence and satisfaction. And it ultimately came down to a scope issue because this is just a master's thesis. But also I think the nature of the research question is more a qualitative approach might be better, because I'm really trying to go after the challenges, the stuff that's ambiguous. And so I wasn't really focusing so much on accuracy. It's really about satisfaction and confidence. The accuracy was more of just something that I was trying to get out from their like gestalt level, or their ability to interpret from the CQL what the measure is intending to capture.
So just thinking forward in terms of adoption, right? So if really what you're interested in, your like overall question is, are people going to adopt this language? Is that maybe why you're more interested in satisfaction and confidence? Because regardless of how good people might be at it, if they don't like it, they're not going to use it.
Exactly, yeah. And it's brand new. They actually are going to release CQL officially, I think, this fall. So, exactly right. Let's see how good it is, and then I guess people don't have a choice about what they're going to use, because they have to rely on whatever CMS puts out for the specifications.
Thanks for the presentation. I can't wait to hear your results. I wanted to, I think you answered the question. You're going to do some of these interviews virtually, and some in person, or will they all be virtual?
Probably majority virtual, just because the HL7 working group, those people are all over the country.
Okay.
So I'll probably use, I don't know, I use Zoom currently on some other projects. That works pretty well.
And then will people have familiarity with the new format, or will you, like, I'm just wondering how much of your time you might have to spend explaining to them before you get, because it sounds aggressive to go through 2 measures with them in an hour on the phone, although I agree it would be awesome to do more than one.
Yeah, that's a good question. Like, I'm in the recruitment phase, the identification of experts. Like, I'm not actually sure if it's a good idea to include people that are too familiar with CQL, because they're going to be biased. Right. They're probably just going to say CQL is better, or they'll want it to be better, or they'll actually think it's better because they helped develop it in some way. So that's exactly why I'm doing the pilot, I think, and I'll pick people at different levels. I don't know, maybe I didn't talk for too long here. I could probably abbreviate a lot of the intro of this talk, but even I think like if I spent 5 to 10 minutes doing like a similar intro to what I did in this talk, it might be enough. And if it's not, if I learn in the pilots that it's not, I could send out pre-work or some type of link to the ECQ Center to get people up to speed. But I agree with you. That's why I originally wanted to show all 4 of those measures, but I don't think it's not possible in an hour.
I'm going to ask a question. I have 2 questions. One is, so what? Like, why does this matter? Do you have any evidence that these implementations, that there's some kind of problem with them? That's a leading question. I know the answer, but you guys don't. And the second is, it gets at learnability. So, are you actually assessing learnability in the way that you're describing this, and how are you going to accommodate that people probably know HQMF and not CQL in that concept?
Okay. So the first question, as you know, since we've studied this with working with these clinics, is that there are problems there, and we studied the variation in these implementations of these measures. So specifically with the update process, we looked at that. Like, some people will be submitting old versions versus new versions of the measures, and a lot of times these change. they change the patients who are included, and that can result in differences in performance. Also, when I go out to clinics, a lot of times they don't have back-end access to their data, and so they use some type of front-end UI query builder, like similar to reporting workbench, to try to estimate the logic. And so they sometimes will shortcut the actual measure specifications just to try to get something close. And I think they end up reporting that stuff to CMS a lot of times as well. And so I think that's part of the reason why I'm interested in this. And the so what is, ideally, we want standard representations of these measures so that we can compare the performance across sites and then tie them to payment. Because right now, I don't know how it's tough to do that, because we have this data and we've looked at the variation, and it's bad. Clinics also.
How bad is it?
Well, I know that we did this analysis for different look-back periods. Like some clinics can report the full 12-month look-back period, and some can only do either a quarter, 30 days, or a quarter, 90-day or 6-month look-back periods. And I don't remember the exact numbers, but I know that there was a lot more variation in the non-standard look-back period versus the clinics that could submit the 1-year look-back period. So that's evidence that having a standard, closer to standard representation might be better. So your performance is a better bell curve, basically. So for your second question about learnability, yeah, that's a good. I actually don't really know. I guess that's part of the process I'll learn through the pilot. It's actually something I'm concerned about as a risk for my methods is that's why I mentioned like the order that I have to show the measures. Like, so I've thought about this. Like I could do I could randomize it somehow so that for one interview I would show the CQL first. And also the order of the measures could be random as well. I could show a complex measure with CQL first, and for the other person, maybe it would end up being a simple measure with the HQMF version first. So I think that's how I could try to address that, mitigate that risk. And then also I'll be collecting their self-reported expertise in these areas, so I can try to analyze the data that way by expertise level.